thank everybody for joining us again for our afternoon session. We appreciate your time and your attendance. Our next session, our speaker will be Ashley Lauriello, and she is a nurse practitioner at Johns Hopkins Adult Sickle Cell Center. She is an advanced practice provider manager and program manager at the Sickle Cell Center for Adults. She has worked in Johns Hopkins and healthcare systems for the past 12 years in hematology as a nurse and nurse practitioner. For the past 7 years, she has worked specifically for the Division of Hematology at Johns Hopkins University School of Medicine. She has partnered with community organizations to provide education to CBOs and local community emergency EMTs in the region. And she has worked with schools of nursing and physician assistant programs to improve education regarding the care of people with sickle cell disease. She is a facilitator of a fantastic advanced provider Project ECHO, extension for community healthcare outcomes that provides expertise to community advanced practice providers to provide education and evidence-based practice guidelines for sickle cell disease management. And I'll just say that this is a phenomenal ECHO, and it's amazing the information that's provided to advanced practice nurses and PAs. Her research has been to work on building a standardized advanced practice provider curriculum in sickle cell disease. She has also assisted in building a toolkit to help build infusion centers throughout the country to provide specialized care for people with sickle cell disease. She will be talking about blood transfusions and sickle cell disease. Thank you. It's all yours.
Thank you so much, Yvonne, for having me. I'm just going to share my screen here. And start the slides. Thank you so much. It's really a pleasure to speak to all of you today. And I'm going to talk today about blood transfusions, sickle cell disease, and the urgency of blood transfusions in minority communities. And as Yvonne said, my name is Ashley Lauriello, and I'm the Advanced Practice Provider Manager and Program Manager here at Hopkins in the Adult Sickle Cell Program. These are my disclosures. So today I'm going to talk about the acute and chronic complications just briefly of sickle cell disease, and talk about the role that red blood cell transfusions have in the treatment of sickle cell disease and acute and chronic complications, and explain the importance of diverse donor pools to meet the needs and the transfusion needs of people living with sickle cell disease, and illustrate how blood donation crisis and can directly impact the care of people living with sickle cell disease. So this is just a brief overview, and this is was published by Vinchinsky, and I love this diagram because it really illustrates all of the complications of sickle cell disease, acute and chronic complications. And as you can see, it's the entire body, right? From head to toe, the red blood cells, they go everywhere. And so people living with sickle cell disease can have issues that are acute and chronic related to the sickling of the red blood cells. Some of these are indications for transfusions, either acute or chronic, which I'll talk more about. But I love this illustration because it really just shows all of the severe complications that can happen to people living with sickle cell disease. Our treatment options are very limited when it comes to sickle cell disease, and it took us almost 20 years after the FDA approval of hydroxyurea to get another drug FDA approved for management of sickle cell disease. So now we have 4 drugs that actually can be used in the management and prevention of crisis. Not all of which that have been shown to reduce the amount of transfusions that are needed in our patients that are chronically anemic and that can have acute and complications requiring blood transfusions. Hydroxyurea is one in the randomized controlled trial that did show a reduction in blood transfusion need, but the others, there's more data that's needed. And so as you can see, you see our drug cabinet of the 4 drugs that have been FDA approved. And then you see off to the side, you see the blood, and that can be used as disease-modifying therapy. It also can be used in severe life-threatening complications of people living with sickle cell disease. I want to talk a little bit briefly about the different types of transfusions, and these are really dependent on institutions and the ability to be able to provide exchange transfusions, which is one of these, and just the resources that are there. So I'm going to talk a little bit about simple, partial, and automated exchange transfusions, as well as sort of the indications for each of those for acute and chronic complications of sickle cell disease, and what current literature that we have out there for those indications. So simple transfusions, I think this is the most commonly used type, the most commonly known type and accessible type, where we're transfusing 1 or 2 units of packed red blood cells to a patient. For patients that have anemia, that are symptomatic, can certainly improve dyspnea, fatigue. In patients that have heart failure, that are very symptomatic and need that increased oxygen carrying capacity of the red cell, simple transfusions can be used, certainly cautiously with balancing volume constraints with people that have heart failure as well. And it also helps decrease the hemoglobin sickle percentage. And so for our patients, reducing sickle percentage can help long-term with vaso-occlusive crisis in the future, but it also can help with reversing some of the complications, the acute complications of sickle cell disease. So this is, a regular transfusion that we think about, given through a regular peripheral IV that can just be transfused without any other sort of extra machinery, technology, or education needed. There are some risks with simple transfusions and with all transfusions, particularly, and this is not something that's just for simple transfusions, but for all transfusions with people with sickle cell disease, there is a risk of alloimmunization, and we think this occurs in about 30% of adults who receive frequent transfusions. This can lead to very difficulties in finding blood availability for patients. It can lead to severe complications like hemolytic transfusion reactions or life-threatening hyperhemolysis, where patients' blood is being hemolyzed that they're receiving, but also their own blood as well as being hemolyzed. And so it can be a very scary and severe complication. And then it may impact, alloimmunization may impact the accessibility of curative therapies, which I'm not going to talk about today, but certainly can impact our patients and the management of our patients as well. It also can lead to iron overload, and I give this statistic to nurse practitioners and nurses and physician assistants that I'm working with, that typically about 2 units of blood is equivalent to what we take in an oral iron in an entire year. So if you think that if someone's on a chronic transfusion program, or if they've received several units of blood over their lifetime, you can see how that iron can accumulate over time and can deposit into organs and may require some therapeutic options for that as well. There's a minimal risk of infection. Most blood is tested by places like the American Red Cross once they're delivered, and also in local blood banks for common infections like hepatitis, HIV, also bacteria and protozoan, and then checked very thoroughly prior to being given to that patient. But there isn't a zero risk. It's much less because they're pretty stringent on the rules and regulations of what needs to be tested in these units, but it's not a zero risk. There's also a risk of viscosity in these patients, and we know people with sickle cell disease, their threshold for viscosity is much sooner than in people that don't have sickle cell disease. And so if patients with sickle cell disease hemoglobins go above 10 or 11, they're at higher risk of getting hyperviscosity, which could lead to stroke, worsening crisis, because you're thickening the intravascular space that can slow things down and cause more pain. There was one retrospective study that looked at simple transfusions, blood transfusions in people with sickle cell disease, and maybe some limited data, some small data, that maybe there was a higher rate of hemorrhagic strokes in that population. Again, limited retrospective study, but just something, an additional thing to sort of think about with patients that are receiving transfusions on a chronic basis. I'm going to move on to automated exchanges. This is a way to rapidly reduce the concentration of hemoglobin S fractions. So if you think about a regular simple transfusion, a unit of blood probably reduces hemoglobin S fraction by about 10 to 15% per unit. People with SS disease make 90% hemoglobin S. With one automated exchange, we can usually get people to close to 30% hemoglobin S, so a pretty rapid reduction. It can be used when simple transfusions could result in hyperviscosity. So in patients that maybe have higher hemoglobins, but maybe they have an acute complication like acute chest syndrome or issues with volume, you can utilize an exchange transfusion. And it is the most useful for severe complications. So for patients that are having an acute stroke with severe acute chest syndrome that are on a ventilator, it can rapidly reduce the hemoglobin S fraction and help with sort of recovery and improvement from those conditions. It does replace sickled cells with normal red blood cells and helping further vaso-occlusion that can happen in the future. It doesn't reverse everything, but it can help anything pre-existing and lower what's happening. So all of that endothelial damage or endothelial adhesion that's happening, all the inflammation, it can lower some of that because the sickled cells are circulating at a less rate. It rapidly reduces bilirubin, can help decrease damage to renal tubular cells, and it can scavenge that nitric oxide and free hemoglobin that's released by the sickle red blood cells. Again, alloimmunization can occur with all transfusions, probably more of a risk in people getting exchanges versus simple transfusions, because there is a requirement of much larger amounts of red blood cells that are needed. So with a simple transfusion, maybe you're giving only 1 to 2 units of blood. Exchanges are based on height and weight, and they could be, anywhere from 4 to 12 units of blood at a time at each exchange transfusion. So there's just a higher exposure of red blood cells. There is a risk of iron overloaded. There have been some studies that have been suggestive that, and just anecdotally, clinically, for patients that have higher hemoglobins prior to starting with exchanges, maybe there's a little less of an iron burden with those than with patients that are getting simple transfusions, but still a risk. And then for patients that are severely anemic, so hemoglobins of 4, hemoglobins of 5, there could be hemodynamic instability with an exchange transfusion. So for some of these patients, they may require a simple transfusion to sort of top them off, get their hemoglobin higher to be able to get them on the machine. So with an automated exchange, they're hooked up to a machine. They require 2 access points, one that's sort of pulling off blood, the other that's giving blood at the same time to help rapidly reduce the hemoglobin S fraction. And if you have too low of a hemoglobin to really even circulate through that machine, you can have hemodynamic instability. There's risk of citric toxicity because of just higher amounts of units, higher amounts of citrate, but can be treated with calcium. And it requires a really large bore IV, in some cases, a Shiley or a large dialysis type catheter, a port, like a vortex port. We do have a protocol here, and I know other places where they use large peripheral IVs, but still like 16, 18 gauge needles. And if you know our patients, right, that may have difficulty with access, this can be challenging. Partial and manual exchanges. So these can be utilized in patients that maybe don't have access to an exchange transfusion. So most tertiary care centers have the ability to do exchanges, but community hospitals usually don't have the ability to actually have an exchange or an in-house exchange program. They may have the ability to have a resource out that they can bring in. But for some patients that require, that have higher hemoglobins, like hemoglobins of 9, that we worry if we give them 2 units, they're going to be past 10, and we worry about hyperviscosity, we can utilize a partial manual exchange mode where we're actually pulling off or phlebotomizing a patient and then giving blood afterwards. In an adult patient, typically we're phlebotomizing a unit of blood and then giving about 2 units back, dependent on the patient. For pediatric patients, there are weight-based models for the amount of blood you're giving and then the percentage of what you're actually taking off, just because children are much smaller than our adult patients. The benefits are that you don't need the large bore IV. You can use just a standard peripheral IV. Usually we try for a 20 gauge, but can sometimes make it work with smaller needles, but doesn't need that like 16 or 18 gauge that you may require for exchange or a vascular access device. There's not the training sort of aspect. It's fairly easy to teach someone how to do therapeutic phlebotomy, just having protocols in place. You don't need the large machine that you need for an exchange transfusion. You don't need the sort of training involved in trying to manage the machine with exchange transfusions. You required specialty nursing and pathology and things like that for those sorts of cases. So this can be done sort of in community settings as well. It does prevent the viscosity in patients with higher hemoglobin, so people that may require transfusion, that maybe we worry about hyperviscosity in patients with a regular simple transfusion. It can be utilized, and there's less blood required for patients, so there's less of red cell alloimmunization in comparison to the automated exchange. These are some of the indications. So these are some of the acute indications, and this came mostly from the NHLBI expert panel report that was published in 2014 that you can actually see. And if anyone needs links after this, I can send them to you. But helpful for sort of looking at sort of indications, acute indications for simple versus automated exchange transfusions. And as you can see, for simple transfusions, sort of symptomatic anemia, these patients that have low hemoglobin levels, aplastic crises, maybe that don't have severe acute chest syndrome, but have a lower hemoglobin, they could get a simple transfusion versus an automated exchange. Patients with splenic or hepatic sequestration, and in sort of preparation for maybe non-major surgeries. Exchange transfusions are for patients really very acutely ill, acute neurological events, severe acute chest syndrome, multi-system organ failure, in preparation for a major surgery. If they have refractory, splenic or hepatic sequestration, these are some of the indications, acute indications that we need transfusions. So in patients that, these are for patients that, are not just coming in for uncomplicated vaso-occlusive crisis, that are fairly sick in the hospital, that, could be in life-threatening situations without blood transfusions. There are some chronic complications, and I have lots of stars here because there is some low quality evidence in some of these. The ASH 2020 guidelines does talk a little bit about this, about different sort of chronic and acute complications as well. So I really direct you to both of them, and happy to share both ASH 2022 transfusion guidelines as well as the NHLBI guidelines regarding acute and chronic transfusions. They can be utilized for stroke and abnormal TCDs in patients. And those are probably the biggest recommendations and the most research that we have. There's also some research about patients that are pregnant and utilizing those as disease modifying therapy and prevention of complications, although that data is also limited, as well as pulmonary hypertension, as tertiary, as it's sort of not primary, but maybe second or tertiary management of patients with recurrent refractory vaso-occlusive crisis that are frequently hospitalized, or recurrent or refractory acute chest syndrome. These are just some of the guidelines, the transfusion guidelines for clinicians that I talked about, 2 of those, but also the American Society of Apheresis in 2019 also provides some good transfusion guidelines for clinicians that are caring for people with sickle cell disease. ASH also came out in 2016 about transfusions and sickle cell disease, and it was actually a pretty large consensus report that talked about all transfusions, and they did have a specific discussion about sickle cell disease. And one thing that they said is that that we should, that they don't recommend transfusions for asymptomatic anemia. We know our patients are anemic at baseline, and so we know that during crisis, maybe their hemoglobin may drop by a gram, but if they're asymptomatic, to try to avoid transfusions because of that risk of alloimmunization that can occur. I get this all the time from being in the hospital and working with residents that they ask me, well, what's the patient's hemoglobin goal? Like, what do you want their hemoglobin to be? And the answer is, I don't have a hemoglobin goal, right? Certainly, hemoglobins of 4 and 3 make me extremely nervous, and probably going to start thinking about transfusing patients. However, we're really looking at the entire clinical picture. Are they having complications? Are they symptomatic from their anemia? And really weighing the risks and benefits of sort of the acute chronic complications related to the person. Vaso-occlusive crisis alone, uncomplicated, is not an indication for transfusion. Like I said before, it could be used as secondary, tertiary management for prevention of crisis, but in the moment of having a vaso-occlusive crisis, there really isn't that much of a benefit to getting transfused right then and there. Really what you're doing is preventing their next crisis from happening. Transfusions, like I said before, without any clinical indication, alloimmunization is one big concern, but also iron overload is another concern. This is from the ASH 2020 guidelines and just some recommendations on transfusions. And this is going to sort of pivot my talk just around the importance of antibodies and why we care about specific donor pools when it comes to sickle cell disease and sickle cell disease management, and how that impacts our blood supply as well. So they made 2 recommendations in this consensus guidelines in 2020. And the first was extended red cell matching profiles and genotype testing and serology for patients with sickle cell disease. And they included certain phenotypically antigen profile matching that should be done for these particular patients. And then making sure that that's shared across hospital systems, because we know if you get a type and screen on somebody, if they're not necessarily expressing the antibody, doesn't mean that they can't make the antibody in the future. And so usually, at least at our institution, we will typically do genotype testing, where we will test to see and phenotype testing to see what their propensity to make these antibodies are. For patients that have been transfused, the phenotype is not that easy to figure out, because if they have transfused blood, you're going to have a mix, right, of what's their blood and what someone else's blood is. And so the genotype testing does help tease some of that out. And then the second recommendation from the ASH 2020 guidelines was around prophylactic matching and making sure that we're matching for those common RH groups that are common amongst our patients with sickle cell disease, the C, E, and K antigens, as well as the ABO and the RH markers as well, and providing those antibody-specific testing for those patients, decreasing the amount of times that alloimmunization can occur. So if they get blood that's off the shelf, could potentially have one of these antibodies in there, and it could lead to alloimmunization and them developing more antibodies that can cause problems in the future with us being able to find blood. In patients that have more than these antibodies, they also recommend extended matching for those specific antibodies to provide protection against hemolytic reactions, but also in protection against developing more antibodies. So there are some clinical sort of considerations with this. So really, like I said before, there's not a great way of actually communicating this amongst hospital systems. So one thing is really making sure doing a complete, transfusion history, looping your blood bank into that, making sure that blood banks are speaking to one another. So if you have a patient that's new to you or has been transfused at another hospital, that the blood banks are communicating with what has happened, what antibodies they've seen, to make sure that if they're going to require transfusion, they're getting the right type of blood. Because we know unmatched blood can lead to alloimmunization, like I said before, and then also those severe hemolytic transfusion reactions. When we don't have units available, especially when they build up lots of antibodies, it can delay and it can really complicate care. So there are some patients that are heavily alloimmunized that it may take days to find blood, and you might not have days in somebody that's got a severe acute chest syndrome or is having a stroke that needs immediate exchange transfusion, immediate blood. So trying to limit the sort of unnecessary blood transfusion needs, so that if they do come in, hopefully not with a severe complication, we have the blood available for them. This is directly from the American Red Cross, and this is just about sort of red cell antibodies in general. So they're a little bit different than just sort of our ABO compatibility A, AB, and O. There are lots of different antibodies that I sort of alluded to a little bit on a couple slides ago. There are over 600 that are known in antigen types that we know about, and they can be unique to race and ethnic groups. 1 and 3 African-American blood donors is a match for somebody with sickle cell disease. And you can see that these are sort of these rare blood types are specific to each type, ethnic group, and it is specific to that. So more minority, more ethnic group donations is extremely important, especially for our sickle cell population, especially when we look at these numbers that 1 in 3 could be a potential match for somebody with sickle cell disease, whereas somebody in another ethnic group may not be able to provide those specific antigens for that particular patient. There's lots of barriers, as I think many of you could probably say, and facilitators for blood donations. And I found this meta-analysis and systematic review where they looked at 15 different articles that addressed this. And there were in this total article that was published in 2019, which was before COVID, which I'll briefly talk about sort of the restrictions around COVID-19 and how that had impacted our blood donor supply. But in total, these articles, there were 3,698 participants, 2,125 were Black or African American, 874 white or Caucasian, and 699 that were other or unidentified. There were common themes that sort of talked about what facilitators and barriers of blood donation were. One facilitator was sort of knowing a blood recipient, so knowing somebody, knowing, for example, knowing somebody with sickle cell disease that needs monthly blood transfusion because they've had a stroke, and sort of understanding sort of the importance of those blood donations. In addition, sort of identifying with culture, race, and religious affiliations. So, churches, faith-based communities that had blood drives, and also awareness sort of around transfusions was found to be a facilitator for more people to donate blood. And then barriers, I think many of us can probably already sort of know this, a lot of the medical mistrust and misunderstanding associated with blood transfusion, but also with just the medical system in general. So the Tuskegee syphilis study, right? Restrictions in the 1980s of African Americans being able to donate blood, concerns that their blood was going to be discarded, because in some cases they were discarded, right? So if I donate, and what are they going to do with my blood? Are they going to actually be able to use it, or is this just a waste? Or being told by a blood transfusion, whether that be in the 1980s, or not giving a clear example of why I am not able to donate. So just not, you can't donate, you've now just been excluded. Really are just maybe just some of the examples of sort of the barriers of being able to get more diverse donor pools. And this was in 2019. And then, as you know, the end of 2019 and 2020, then COVID hit. And you can see all of these news articles about critical shortages of red blood cell donations, emergency blood supplies, decreased donor turnout, that really just sort of flipped everything on edge as well, and that we're still recovering from. We also, with these blood shortages, this does have a huge impact on our ability to be able to transfuse patients and keeping up with those antigen, red cell matched units. This was published by Dr. Jones, who was a hematology fellow here at Hopkins and is now transfusion medicine fellow at Pittsburgh, who looked at populations and collections over time and how that can potentially impact. And you can see the sort of this first red line is the collections per 100,000, and then transfusions by 100,000. And as you can see, the blood donation sort of even between 2011 into 2019 before COVID had already started to decline. And then we had, the severe blood crisis during COVID-19 to make that even less. And so we have even less of a donor pool and in a population of patients that need really specialized blood.
Ashley, thank
Yes.
you so much for this. This
Yeah.
is just phenomenally important. I feel smarter already just having sat here with you this, past few minutes. We really appreciate it. We do have a couple of questions. Maybe you
Yes.
want to finish this slide and then we can go to questions, or
Sure. No, that sounds
would that be
perfect.
okay?
This is a good stopping point. So this is just the impact on sort of COVID-19 blood transfusions and sickle cell disease. And these were some of the ASH guidelines about transfusion around COVID-19. And so you can see here, like, that they, restricted sort of the amount of transfusions for people that are getting scheduled transfusions. They talked about maybe adding in low-dose hydroxyurea, right? So things that like we wouldn't normally do, but sort of this crisis management that I think is getting better, but we still have a long way to go.
Oh, awesome. Thank you so
You're
much.
welcome.
This is so helpful to all of us that are working in this space. We really appreciate it. So let me just start out with a question. We have here for partial and manual exchanges. Do you take off 1 unit of whole blood and then give back around 2 units of just RBCs, is what the question says.
That is correct. Yep. So whole blood take off and then 2 units of just packed red blood cells.
Awesome. Great question. Thank you so much for that. And I heard that there were some other questions. I'm just going to ask people to unmute because for some reason I only see the one. If you have a question, please unmute and ask your question of Ashley.
So we're going to ask them to raise their hand if they want to ask the question so that we can give them permission to speak.
Thank you.
We have our first one. You're able to speak now. Unmute yourself and speak.
Yeah, good afternoon.
We can hear you now.
Yeah, this is Abdullah Ibrahim Sanko from Sierra Leone, representing Sanko Humanitarian Advocacy for Sickle Cell. First of all, I want to say thank you so much for your time and your efforts you have taken to do most of this presentation, which we have learned a lot. During my schooling days, I was taught that most sickle cell patients, when they do a malaria test, it's negative. I don't know why, or if that thought is really true or not.
I think the question is sort of around malaria testing of people with sickle cell disease. And I think that's a really great question because we know that sickle trait, right, is sort of that protective, sort of that mutation that happened to protect against malaria in people with sickle cell disease. But there is some literature that people with sickle cell, right, sickle cell anemia, not just trait, still have the risk of getting malaria and don't have that protection, partially probably because they're functionally asplenic, but they sort of lose that protection that one gene provided and what that mutation caused. So there's likely patients, right, that are still at risk. And I have patients, in the US that if they go travel to Africa or other countries that I will give malaria prophylaxis to. And unfortunately, I don't know if Yvonne was at our echo, we had a young woman that did not get malaria prophylaxis and actually came back fairly sick with malaria. who was unfortunately pregnant, who, we were able to treat her, and she did well, and the baby did well, but seems to be, and there's some sort of literature to support this, that not all that protective against people with sickle cell disease.
We have one more question here. It says, do you have any suggestions on how to increase blood donation in the African American community?
So great question. And I'll tell you, I'm just going to flip one slide over here, because I think the community provides a huge role in this. So we have community-based leaders, community-based organizations, and I think I've seen a couple that maybe we're going to join here that I know have joined the conference, that I just want to thank, because they play an amazing, huge role in this. In going to local, community-based organization events, but also going to local churches, getting the word out, getting the importance out. I think to really just humanize it, right? And really understand that, what this role plays in these patients. There's so much out there about cancer and, pediatric oncology patients, right? They see the poor sick child, right? And they want to donate blood. But I think this is a population that still needs this as well. Like, these are life-changing, life-threatening things that can happen to them that without blood transfusions can be fatal. And so getting that word out, getting the faces of people that really have better quality of life because of these transfusions, or have been saved by a blood transfusion. We utilize with the American Red Cross Sickle Cell Awareness Month as just sort of a platform in September to try to get more donations during that time. But I think that can also happen. I think education to the communities too. I had a local financial company that came up to me that wanted to do a blood drive during Black History Month, and I gave a talk, and then they had set to their sort of minority based group, and they had blood donations increase. So I think education, getting out there, talking, the community-based organizations, they do an amazing job at really pushing this through and getting the importance of this.
Thank you so much, Ashley. I know it is time for us to move on to our next session, but we greatly appreciate what you shared with us today. So thank you all, and I'll see you all in the next session.